All right, today we'll be talking about musculoskeletal disorders. First thing we'll talk about today is skeletal trauma. Some of you as nurse practitioners will be working in an urgent care setting or an ER and will have to deal with skeletal fractures. Fracture is a break-in in the continuity of the bone. It's a bimodal distribution. Highest incidence is among young males, and then again in adults 65 years or older, typically due to falls and or osteoporosis. Women are more prone to hips and wrist fracture than men, both because they're more prone to osteoporosis and also their bones tend to be smaller in size than male bones, so it makes them more prone to fracture. So there's many different types of fracture. There's a list here. It's pretty self-explanatory. There's complete, which is complete disruption of the integrity of the bone. There's incomplete. The bone is damaged but in one piece. Open fractures, where the broken bone punctures through the skin. Closed fractures are where there's no break in the skin. Linear fractures, fracture line runs parallel to the long axis of the bone. Oblique is kind of a slanted fracture, or kind of, you cut something on a bias. It's that shape. Spiral fractures that encircle the bone. Transverse is where perpendicular to the long axis of the bone. And then there's comminuted, where there's the bone breaks and there's more than two pieces. And this is a diagram that illustrates all the different types of fractures that we discussed, plus a few more. Aside from how the bone is broken, whether it's open or closed, so on and so forth, you can also classify fractures based on their pathophysiology, or how they occurred. You can have fractures from tumors. So the tumor grows within the bone and weakens the bone and makes the bone fracture. You can have fractures from infections. You can get an osteomyelitis. So the infection is in the bone and weakens the bone and makes it more likely to break. It can be from osteoporosis, which is a weakening of the bone. This is more common in women. We'll talk about that a little bit more in detail. And then also there can be endocrine or metabolic disorders that can make people more prone to fracture. Stress can be another cause of fractures. It can either be from cumulative stress over time, or it can be from acute stress in a short amount of time. People who experience these types of fractures are typically involved in sports. You'll hear about a lot of gymnasts with stress fractures of the lower extremities, just because the amount of force that they place on these bones and the amount of times that they do that. Elite gymnasts will practice 3 to 5 days a week plus competitions, and they'll be practicing for say 4 hours at a time. So they put a lot of stress on their bones. People who do repetitive motion for their job can put stress on their bones and cause stress fractures. And then also military training is another classic example. When people go through boot camp, or if they go through special ops training, they put a lot of stress on their body, and it's not uncommon for these people to be dropped from whatever training that they're doing due to stress fractures, and they'll have to let those fractures heal and then reattempt whatever that they're training for. So the pathophysiology behind bone fractures. So basically what happens is the bone breaks. Obviously, that's the first step. Once that happens, you have a disruption of the periosteum, which is the um, outer lining of the bone, and then also there's blood vessels involved there. The bone is highly metabolic, or a highly metabolic structure. So there's a lot of blood vessels in bones, and there's certain bones that are much more likely to bleed than others. For example, if someone experiences a pelvic fracture, you can have massive, massive amounts of blood loss with a pelvic fracture. So anyone who does trauma or ER nursing, you probably experienced that firsthand. Um, and it's when you have a fracture in a bone and there's bleeding involved, it's hard to put pressure to stop the bleeding. If you have a surface wound, you just put pressure on it and it stops the bleeding. With bone, it's much more difficult to do that. Oftentimes, if people have a pelvic fracture, they will they have these devices that can put around. It's sort of like a girdle. They put around and they cinch it tight, and it puts pressure on the pelvis to help stop the bleeding. But it's not uncommon to lose 1 liter, 2 liters of blood from a pelvic fracture. Same with the femur fracture. You don't lose quite as much blood as with a pelvic fracture, but you can still lose significant amounts of blood. So something to consider. Anyway, back to our discussion. So bone breaks, disruption of periosteum and blood vessels. You get bleeding at the damaged ends of the bones. The bone adjacent to the fracture dies. Get necrosis. And initiates an intense inflammatory process. So again, bringing things back to our first week's discussion. The inflammatory process includes vasodilation, get leukocytes, mast cells, all that kind of stuff. Get cytokines to promote healing. Blood flow to the injured area increases to promote healing as well. Obviously, if you're trying to rebuild something, you need to get oxygen and nutrients to that area to help to get that rebuilding to occur. The osteoblasts and osteoclasts are activated to form procallus over the fractured bone. So the healing occurs in 3 phases. It regains most of its structural integrity in 6 to 8 weeks. That's typically why people have casts for that period of time. Final remodeling of the bone can take months to years. Bone is unique in that it can repair its own tissue without scar. The liver is like that as well, as a side note. But that's important because when the bone rebuilds, you want it to be exactly the same as it was before. So that way it has the same shape and integrity and can carry out the same functions as it did originally prior to the fracture. So clinical manifestations of fracture. The one we're probably most familiar with is pain. I don't know if anyone's ever fractured a bone. I had a hairline fracture in my wrist when I was in high school, and it was incredibly, incredibly painful. You can also get muscle spasms with fractures due to the pain and disruption of nerves that run near bones oftentimes. A classic example of this is people who have rib fractures. In Missouri, we have a lot of deer hunters, and it never fails that starting in deer season in the fall, these people will go into deer stands, and it's cold outside, so they'll be sipping on a little bit of bourbon or what have you, and they always get a little tipsy, and they tip over their deer stand and fall. So they'll fall from a 2-story height onto the ground, and you can imagine they probably land on their side, and they have rib fractures. And so they'll come into, say, a trauma ICU, and they'll have incredible, incredible pain. These people are typically on the larger side, very rotund, probably have COPD, probably smokers, probably don't have the best lungs in the first place. So they'll have these rib fractures, and it's very difficult for them to take a big, deep breath, and couple that with their bad lungs from whatever they've done in the past. They can have some really bad lung issues. And so the best way for them to ensure that they're breathing well is take big, deep breaths. but every time they do, they get a muscle spasm from the rib fractures that they sustained. So you can imagine how that works out. Not very well for them. So, how do you treat this pain? Well, the obvious choice, or I should say the choice that most people think about first, is opioids. They're really good at treating severe pain. You give them IV, and you think they'd be good to go. But the problem is, we know that opioids suppress your respiratory system. So if you have someone who's not taking big, deep breaths like they should, and then you give a respiratory depressant on top of that, how do you think that's going to work out for them? Probably not very good. So what makes more sense to treat the pain is the muscle spasm, or to treat the muscle spasm. Because every time those muscles contract, they're making broken bones rub against each other and causing severe, severe pain. So if you treat the muscle spasm with, say, Flexeril, you can control the muscle spasm, it controls the pain at the same time, and it also allows these people to take nice, big, deep breaths without having further muscle spasms. So that would be the best choice in that kind of a scenario. So if you ever have someone come in with rib fractures and they're having a hard time breathing and in a lot of pain, obviously you want to give them some opioids, but you also want to make sure you get some muscle relaxers on board as soon as possible. Not only do you have injury to the nerves that run near the bones, you get the muscle spasms, you can also get edema and inflammation of the adjacent soft tissues, which has to be managed. And all those things together cause severe pain. You can have bleeding like we talked about, impaired sensation, unnatural alignment, deformity of the bones, and impaired function of wherever that bone is. So the treatment for bone fractures is, number one, to realign the bone. So that way when they heal in their normal alignment, and then you ensure that the bone will regain its normal function once it's healed. So there's a couple ways to do this. You can do a manual reduction, which is where you manually move the extremity and the two pieces of the bone into alignment. You can either do that in the ER, over the skin, or depending on where the fracture is and how the bone is fractured, you may actually have to take someone to the OR and open them up and do a reduction within the skin on the bone directly. You can also do reductions by applying traction. I don't know if people have seen that. I don't think it's quite as common as it used to be, but basically they can put a pin in part of the broken bone and apply weight to it, and by applying weight, it pulls everything into alignment. So once you have a good realignment of the bone, or reduction is what people commonly refer that to, you want to do what we call a mobilization or fixation, which is where you take the two pieces of the fractured bone that are put back into alignment, you keep those bones in alignment so that way they can heal naturally. So there's many different ways to do that. You can do it through a plaster cast. You can also do it surgically through applying plates and screws to the two pieces of the bone to provide some mechanical stability. Or you can do it with external fixators, which I'm sure you've seen those before, which are basically you put multiple pins through each part of the broken bone, and then you get a metal, several metal pieces on the outside that tie those pins together and keep them in alignment, and thus keep the bone in alignment. And I'll show you some pictures of those here. This is an example of an external fixator. As you can see, there's pins. They're kind of hard to see, but so you have a pin in the proximal part of the bone and then in the distal part of the bone. So the fracture would be in the middle here. And these rods are used to provide structural rigidity to help keep those two bones in place. On the other side of the picture, you can see an example of a cast. So this would be another type of fixation. So you get 2 of the 3 types of fixation within this one picture. And probably what you'll see in this person, probably a week or 2, is that they'll have an internal fixation with rods or plates and screws. So at some point, this person will probably have all 3 types of fixation. The reason why they probably haven't done that initially here is because, like we talked about earlier, when you have a fracture, you have a lot of inflammation, have a lot of edema, a lot of swelling. It's difficult to get good permanent fixation when you have a lot of edema and swelling. It's not the most opportune time to have a permanent fix. So you can do external fixation, let that swelling and edema resolve over a week or 2. As you can see, this person's legs elevated at the same time to help with that swelling. So once that swelling goes down, then it's much easier surgically to go in and see what you need to see and repair things. While part of it is to allow a better healing, a lot of it is to provide the opportunity for the surgeon to have really good visualization. There's a lot of swelling and edema. The surgeon doesn't have as good visualization, and it's more technically challenging to get a good permanent internal fixation. So dislocation and subluxation. Dislocation is a temporary displacement of the bone from its normal position in a joint where no contact is retained. May or may not be associated with a fracture. Typically, these dislocations require a moderate to severe amount of force in order for this type of injury to occur. So you can imagine if there's enough force applied to dislocate the joint, there also may be enough force to cause a fracture. It can be congenital or acquired. A lot of people who have certain diseases that makes them more flexible than normal, they can get dislocations because their joints have an abnormal amount of range of motion. Say someone with Marfan's, they would be someone who's prone to a congenital dislocation. Increased risk for rheumatoid arthritis in the future. Just from the disruption of the joint multiple times, it can cause inflammation and it can stimulate the development of rheumatoid arthritis. May also be associated with injuries to the tendons or ligaments or nerves. We know that tendons and ligaments have a role within creating the structure of the body. They help to keep the bones in a normal alignment, and they also help attach the muscles to the bones. So if there's a significant force applied that disrupts those joints, the tendons that keep those joints in alignment can get torn, which would need to be repaired, and also it can disrupt the muscle from the bone, that attachment there. And also what can happen with that is the muscle gets detached from the bone. That itself can cause fractures too. And as we know, that nerves kind of run kind of contiguous with the bone. And so if you have a disruption in the bone or the joint and there's nerves around those joints, those nerves can get injured. Subluxation is a displacement of the bone from the joint where there is some contact retained. So basically, it's sort of like a partial dislocation. So when you hear subluxation, where the joints touch each other, there's still some touching of the joints, but it's still out of alignment. With dislocation, there's a complete disassociation of the bones from one another. So the joint, there is no contact whatsoever. Both are treated with immobilization for 2 to 6 weeks. That's to allow the swelling and edema and everything to go down back to normal, to let that inflammation die down quicker. If you have a disruption, you have inflammation and edema, and you try to move that joint, it's just going to cause further inflammation and edema, and then eventually increase the risk of the joint not healing perfectly, and also increasing the risk of rheumatoid arthritis further on down the road. Sprains and strains. Sprains are tears in ligaments, and then strains are tears in tendons. So a good little mnemonic to remember this is strain has a T in it. T is for tendon. Tendons connect the skeletal muscles to the bone. And sprains, they do not have a T in it. So those would be the ligaments. Unfortunately, there's not an L in sprain. Otherwise, that'd really make this mnemonic work a lot better, but you kind of get the gist. These are both treated with immobilization for 4 to 5 weeks. Sometimes it may require surgical repair if there's a significant tear. Sometimes if there's a small tear, they'll just let it heal on its own. But if there's a larger tear, then they'll have to do surgery. And that surgery may involve replacing the ligament or tendon. It may involve doing an arthroscopy where they take a camera and put it into the joint and can kind of use a little shaver to shave off the debris, which can help with the inflammation and help everything kind of run more smoothly together. So it just kind of depends on what's going on. As a personal example, about 2 years ago, I developed a tear in my tendon in my ankle. So basically the tendon, it's sort of like, think about it like string cheese. When it comes straight out of the package, it's all one piece. But if you start tearing it, it tears into linear strands. And that's sort of like what your tendon's like. So if you cause damage to a tendon, at each point of attachment, on one end and the other end of the string, we'll call it, at each end, it's still together, but within the middle, it shreds and becomes a bunch of longitudinal strings that are all kind of separated. And because of that, it loses its integrity, so it's weaker. And then also, when those fibers run together, those linear fibers run together, it can cause a lot of inflammation and swelling. And on Thursday, I can try to see if I can show you a picture of what my tendon looked like or what my ankle looked like. It got very inflamed and swollen anytime I would walk on it. It swelled to the size of an orange after work each day. I tried to rest it with a brace for several weeks. That did not work. So I ended up having to have surgery. And what they did is they did what we call tubularization, which is where they, within the middle of that tendon where it's kind of become shredded like string cheese, they take a piece of, Teflon tape or whatever to use, and they wrap it around, sort of like, trying to think of the best way to describe it. They wrap it around kind of a spiral to make that tendon all one piece again. So while the strands underneath that spiral are still separated, it makes it stronger in one piece again. So that way it has its integrity. So I'm still healing from that. My ankle's not perfect, but it's still a lot better than it was. So long story short, those are sprains and then strains. Rhabdomyolysis and compartment syndrome. Sometimes these terms are used interchangeably with myoglobinuria. So basically what happens here is either from direct trauma or from compression or from excessive exercise, you get a breakdown in the muscle, in the sarcomere. This is a common injury with someone who experiences a crush injury. If they have something that lays on them for a period of time, it can cause muscle breakdown. If someone develops what we call compartment syndrome, which is where in the extremity they have such severe swelling and edema that it causes physical compression of the muscle and the blood vessels, and that physical compression damages the muscles to the point where they break down. That's another example. A third example is people who do CrossFit. They exercise themselves to such a degree and exhaust their muscles to such a degree that they actually cause physical damage to the muscle cells themselves, and those muscle cells start breaking down. So, whatever the reason, because of that breakdown in the muscle, you get a release of intracellular contents. We talked about this with cancer and tumor lysis syndrome. This is a very similar concept, but it's specifically for muscle cells. So what happens is you have a release of the intracellular contents of muscle cells. And muscle cells are somewhat different than other cells as far as their intracellular contents. In particular, they have a lot of protein pigments, which we call myoglobin, which are used to help carry oxygen in muscle tissue specifically. Muscle cells also carry a lot of potassium inside, just like all other cells do. So you get a hyperkalemia. You get a lot of phosphorus release, just like other cells, which causes an acidosis. It can also cause a hypokalemia as well, or a hypocalcemia. Hypocalcemia, not hyperkalemia. You have a lot of sulfates that get released, which also cause an acidosis. And also you can get an acute renal failure. So what happens is these myoglobin proteins are very large, or larger in relation to some other things that the kidneys filter. So these myoglobin proteins precipitate in the tubules, and they block the filtration of the nephron, which is the functional unit of the kidney. So basically these nephrons get clogged with this myoglobin, and they can no longer filter as they should, and it causes kidney damage or an acute renal failure. This can be very problematic, and it can be difficult to treat. Sometimes you'll have to do dialysis on these people. Sometimes in the past, they will put these people on a bicarb drip. And the thought behind that is by raising someone's pH, it prevents the myoglobin from precipitating as much. I don't know if they're still doing this. I've heard conflicting statements as to whether this is a good treatment or not. But that is something that I've seen done in the past, and that's kind of the chemistry behind it. Also, they'll make sure these people get lots and lots of fluids to help kind of dilute them out and kind of keep the kidneys, kind of keep them flushed with fluids to help prevent them from getting clogged up too much. But it can be a very bad problem. So if you see someone who experienced a crush injury, if they were trapped in a building, say with a piece of concrete or something on them, it can be a problem. If someone passes out because of a drug overdose and they've been laying on the floor for 2 days, I've seen this happen. Laying, on their backside, all the muscles on the backside experience rhabdomyolysis, and they get renal failure from the myoglobin release. So long story short, there's many different mechanisms by which this can occur, but if it does, these are the things you want to watch out for. You want to watch out for hyperkalemia, acidosis, and acute renal failure from the myoglobin release. Also, these people can get DIC, or disseminated intravascular coagulation, from the release or the activation of the clotting cascade. And what that is you get such a strong response, or such a strong clotting cascade response, that you use up all your clotting factors, and then because of that you develop a coagulopathy where you don't coagulate as well. So you get an initial hypercoagulation, you use up all your clotting factors, and then you end up having problems with coagulating later on. So the causes, like we talked about, crush injuries, MVCs, falls, pinnings, passing out and laying on the ground for a period of time, excessive exercise, all those things can cause rhabdomyolysis compartment syndrome. Also cellulitis, prolonged immobility, so on and so forth. We kind of talked about all these. There's lots of medications as well that can cause rhabdomyolysis. The HMG-CoA reductase inhibitors, otherwise known as the statins. So these are all your cholesterol meds. They're classically known for causing rhabdomyolysis. Cyclosporins, erythromycins, colchicine. I'll let you read all through these lists here, but these all can cause rhabdomyolysis. Heat stroke, malignant hyperthermia, neuroleptic malignant syndrome. I'll let you read through all these, but basically anything that causes severe strain to the muscles can cause this problem. And this is kind of a flow diagram of the process behind rhabdomyolysis. So with compartment syndrome specifically, there's the 5 P's that we talk about. So these all have to do with impaired blood flow to an extremity or ischemia to extremity. So when the extremity doesn't get good blood flow, it causes ischemia. The tissue, starts dying from lack of oxygen, and these are all the symptoms that you get. So you get pain out of proportion to the injury. You get paresthesias, pallor, pulselessness, and paralysis. So the pain out of proportion to the injury is a result of ischemia to the tissue. So say you have a broken leg. Obviously, it's going to be very painful because there's a fractured bone. However, because of that fracture, you get a severe amount of edema. Say there's some bleeding from the broken bone, and that causes further compression of that extremity. That injury also causes pain on top of the broken bone. So that's why you get pain out of proportion to the injury. You also get paresthesia. So this is a reflection of the nerves within that area not getting good blood flow. It's analogous to when you wake up and you've been sleeping on one side and your arm falls asleep. So that's what a paresthesia is, that tingling sensation that you get. You get pallor, which is, again, a reflection of not getting oxygenated blood to the tissues, so the tissues become pale. You get a pulselessness, which is where, if the compartment syndrome is so severe that the pressure within the tissues is higher than the arterial pressure, you get no arterial blood flow and therefore pulselessness. And then finally, paralysis. If the extent of the hypoxia to the tissues, if it's so severe that it damages the nerves and the muscles or makes them inoperable because of a lack of oxygen, you can get paralysis. So I would memorize those 5 P's because they're classic for compartment syndrome. So we talked about the symptoms. You get muscle pain, weakness, dark urine. That's from the myoglobin in the urine. You get myoglobinuria. Get an elevated creatinine kinase. Again, that's one of those intracellular proteins that's in a muscle. So if you get an elevated creatinine kinase, that's very specific for skeletal muscle damage. You get also hypocalcemia followed by hypercalcemia. We sort of talked about that a little bit, why that is, but we'll talk about that on Thursday. See if you can go specifically step by step why that happens. So monitoring, you want to monitor CK levels or creatinine kinase levels. This is a very useful tool to monitor for rhabdomyolysis. These are the normal values and the abnormal values. Treatment, if it's a compartment syndrome, then you want to do an immediate fasciotomy. So to be clear, you can have rhabdomyolysis without compartment syndrome. So rhabdomyolysis is anytime the muscle cells are damaged and release myoglobin. However, one of the most common ways for the muscle cells to be damaged is through compartment syndrome, which is where you have severe swelling and edema within an extremity, which causes damage to the muscle. So be clear on that distinction, and we can talk about that more on Thursday if it's unclear. But if you have compartment syndrome, which is edema and swelling of an extremity, you have to do a fasciotomy. So your muscles in the extremities are kind of grouped together in very specific ways called fascia, and each extremity has its own corresponding fascia. Your upper extremities, say your forearm, has many more fascias than your lower extremities, and any general surgeon or vascular surgeon will be very familiar with these. And basically, what you'll have to do is, you had severe compartment syndrome. The surgeon will have to go in either at the bedside or in the OR and do an immediate cut down and release each of these fascias and separate them to allow a decompression to restore blood flow to the area. So these can be sometimes emergent procedures that, it needs to happen so fast. Sometimes you just have to slap some betadine on someone in the ER or in the ICU and do a cut down immediately with a surgeon. Oftentimes you may see orthopedic surgeons walking around with a device called a Stryker needle. Basically, it's a device that's made by a company called Stryker, which makes orthopedic supplies. But basically what it is a very small needle attached to a digital device. So you place the needle inside the fascial compartment, you poke it through the skin into the muscle, and it measures the pressure inside that compartment. So if it's elevated, then they know they have compartment syndrome. So treatment, you do a fasciotomy if it's severe. Otherwise, you would just monitor compartment pressures with that needle that we talked about. You want to do rapid hydration to help prevent damage to the kidneys from the myoglobin. If there's severe hyperkalemia, you can do dialysis. You can also do all the other things we know as nurses to help reduce potassium levels, such as dextrose and insulin. You can do K-oxalate. There's some other things that we'll talk about. Albuterol can reduce potassium levels. Do osmotic diuretics to help the kidneys. Bicarbonate to alkalinize the urine. Not shown to improve outcomes. Like I said, that's kind of controversial, but if you see that happening, that's why they're doing that. Osteoporosis, most common bone disease in humans. There's two types. There's primary or idiopathic, and there's also secondary due to endocrine or side effects from medications, toxic substances, so on and so forth. It occurs when the bone is reabsorbed faster than it's formed. So within the bone, there's this constant balance between bone being made and bone being reabsorbed. Both these processes occur simultaneously, and normally they're in balance. So the amount of bone that's destroyed is the same amount of bone that is being made. But when it gets out of balance, that is what osteoporosis is. It's twice as common in women as in men, and that's due to hormonal reasons. Caucasians are also at more risk for osteoporosis than other ethnicities. You get an increased risk of fractures from falls. As we know, when people get older, they start losing their balance and falling. And not only do they fall, but they fall on bones that are much weaker because of osteoporosis. So they're significantly higher risk from getting fractures, particularly of the hips and the femur. Estrogen-related osteoporosis is one of the most common causes. Androgens stimulate bone growth. Estrogen is an example of an androgen. If you have a decrease in estrogen from menopause, then you can get osteoporosis. So what estrogen does is it protects against oxidative stress in bone. So not only do the androgens help stimulate bone growth, but they also help protect against the oxidative stress within bones. So clinical manifestations of osteoporosis are bone deformity, vertebral collapse. We see as elderly people age, they kind of start shrinking in height, and then also start getting a bit of a kyphosis and kind of a hunched back look to them, and that's because of the vertebrae collapsing. Also can get fracture in the long bones, such as the femur, hip fractures. 20% of hip fracture patients die from surgical complications. Hip fractures are very, very devastating to people once they develop them. You could have someone who was very independent, living by themselves, driving, taking care of all their ADLs, and they just happen to slip and fall and get a hip fracture. And you fix them, and then all of a sudden they're immobile in the hospital. They start getting deliriums. They get blood clots from being immobile. They get pneumonias from being immobile and not moving around, or they'll get an ileus and get a bowel obstruction. There's so many different complications that can happen, all related to taking care of hip fracture. So the best way to deal with this is to prevent hip fractures from happening in the first place, both by helping to slow the effects of osteoporosis and also to help ensure people aren't going to fall, whether that's by making sure they have good shoes, non-slip surfaces, things within easy reach, so on and so forth. But the best bet for this is just prevention rather than treating. One of the complications that can happen from bone fractures due to osteoporosis is fat or thrombic embolisms. Being immobile makes you more prone to developing thrombi and those causing embolism. And then also when bones break, you can get what we call a fat embolism, which is where because where the bone breaks, the blood vessels are open. You can entrain small fat molecules into the blood vessels themselves, and those fat molecules travel all throughout the body and can cause embolisms, and they can be very devastating. Also can get hemorrhagic shock. Again, we talked about how vascular the bone is, particularly the femur and the hip and pelvis. If you get fractures to those areas, they can bleed quite severely. This is a classic example of someone who's experiencing the spinal effects of osteoporosis. They have what we call a kyphosis or a hunchback. So this can be very uncomfortable to someone. And can you imagine what their spinal cord is doing when their bones are doing this? Their spinal cord gets stretched, compressed, and they start getting motor weakness, sensory deficits, so on and so forth. So ways to treat osteoporosis: exercise. We know that manual pressure applied to bones is what stimulates bones to grow. So people exercise on a regular basis. They can keep their bones strong and also keep their balance and muscle strong to help prevent falls. Vitamin D is critical to ensuring people have proper calcium levels to help build bone. Calcium supplements help with that as well, and also magnesium supplements. Osteomalacia is inadequate or delayed bone mineralization. So calcium and phosphate required, as well as vitamin D, to help build the structure of the bone to make it hard. Otherwise, the bone is very soft and pliable. Low levels of vitamin D lead to decreased calcium levels, lead to an increased parathyroid hormone secretion, which increases calcium levels but also decreases phosphate levels. So while it increases the phosphate level, while it increases the calcium level, it decreases the phosphate level, and that again can weaken bones. That's why not only is calcium supplements very important, but also vitamin D supplements, because if you have one and not the other, it can still lead to weak bones. Can occur in adult bones. If it occurs in children, it's called rickets. So in adults, it's called osteomalacia. In children, it's called rickets. Risk factors. Most important risk factor is lack of vitamin D. Fortunately, in America, that's not very common, but in other parts of the world, it is. Lack of bile salts equals impaired absorption. So if you have issues with gallbladder, it can lead to osteomalacia. Liver diseases impair conversion of vitamin D to the active form. Vitamin D goes through a multi-step process to become activated. You'll learn about this in Dr. Gopalan's class. But long story short, the liver is critical for this conversion, and if you have liver disease, then the conversion doesn't happen. So it doesn't matter how much vitamin D you have. If it's not active, then it's not doing what it's supposed to do. Also, certain anticonvulsant medications can lead to osteomalacia. So clinical manifestations: skeletal pain, pain between the joints but not in them, facial deformities, and also bowed knees. Treatments are normalizing calcium and phosphate levels, suppressing secondary hyperthyroidism, because that can affect your other hormones that are involved with maintaining strong, healthy bones. Also, chelating bone aluminum, and then performing dialysis. Bone infections. This is called osteomyelitis. In my hospital, unfortunately, this is very, very common. We have a lot of patients that have osteomyelitis for various different reasons. Typically, these are people that have diabetes. So because of that, they don't have very good blood flow to their extremities. We'll talk in endocrine about why diabetes affects your blood vessels. These people also commonly are smokers for years and years and years. That causes peripheral vascular disease, which again impairs blood flow to the extremities. We'll also have people who are IV drug users, and these people are more prone to getting infections in their blood vessels because of using dirty needles, and those infections travel through the blood to the bone. So for many different reasons, whether it's impaired blood flow or increased risk of bacteria in the blood, the bone becomes infected. When you have impaired blood flow to the bone, the immune system can't deal with infections. So you may develop an infection in the bone. Normally, the immune system sends all of its agents that it uses to fight infection to the bone through the bloodstream. So if you have an impaired blood flow to the bone, the immune system can't send its constituents to that bone to heal the infection. And then on top of that, if you have someone who has osteomyelitis and you want to give them antibiotics to help treat that infection, those antibiotics cannot get to the bone infection because of impaired blood flow. So you can see how big of a deal this is. So there's many different ways that the infection initially gets into the bone. It can be from disruptions of the skin or cuts on the skin. It can be from the sinuses, be from ear infections, dental procedures, joint replacements, intravenous drug use, diabetes, alcohol abuse, so on and so forth. Osteomyelitis can be from bacteria, it can be from fungi, mycobacteria, parasites, viruses. All different types of infections can occur within the bone. Like we talked about, there's anything that affects blood flow to the bone can cause an increased risk of osteomyelitis. This can include sickle cell anemia and low oxygen tensions in the blood. So mechanisms of osteomyelitis. So like we talked about, the invading pathogen gets into the bone, provokes an inflammatory response, and inflammation causes vascular engorgement, edema, leukocytes to travel to the bone, small blood vessels end up thrombosing because of the inflammation, and then you get an abscess formation. Clinical manifestations of osteomyelitis are fever, malaise, weight loss, and soft tissue infection. Treatments for this are surgical debridement, intravenous antibiotics, and hyperbaric oxygen therapy. So with surgical debridement, obviously if you get antibiotics and they can't get to where they need to go, you just have to cut out the infection. So a lot of our podiatrists will do these surgeries where they'll go in and they'll just remove all the dead tissue, all the dead bone, and scrape things down to where you start getting a lot of bleeding. When you get to that point, then you know you've gotten all the infection out and you got good healthy tissue underneath. So they'll do these quite often until the wound is healed. We talked about antibiotics can't always get down to these infections, but you still want to have these people on antibiotics. These are the kind of people that'll be on IV antibiotics, not oral, for a prolonged period of time. So it's not uncommon for these people to have PICC lines placed, so that way they can get regular IV antibiotics for weeks to months even. Another treatment that is emerging is hyperbaric oxygen therapy. So the theory behind this is that we know that high levels of oxygen can cause free radicals, and those free radicals can cause damage to cells, not only to our cells in our body, but also to bacteria. So if you bombard these bacteria with high levels of oxygen, it can cause oxidative stress in them. But also, too, what it does is it increases the amount of oxygen to the tissue. So if you have tissue that's ischemic and you do the hyperbaric oxygen therapy, it can get some oxygen to those tissues that aren't getting blood flow normally. And I know we talked about reperfusion injuries and how that can be damaging, but in the balance of things with this particular pathology, hyperbaric oxygen therapy is actually beneficial. So I don't want you to get confused about, last week Wes said that, when you get reperfusion, it causes injury and free radicals and so on and so forth. While that mechanism is true, in the grand scheme of things, the hyperbaric oxygen therapy allows that tissue to get some oxygen that it's needing, so that way it can start healing and repairing itself. Disorders of the joints. Osteoarthritis. It's a non-inflammatory. Notice how I had that in bold, so that's important. Non-inflammatory joint disease characterized by local areas of loss and damage to the articular cartilage with subsequent formation of new bone at the joint margins, or osteophytes. So what's going on here is your joints have cartilage in between them, and that cartilage allows smooth movement of the bones within the joint. It's sort of like lubrication for a joint. Just like you need lubrication when you have two pieces of metal rubbing against each other, the bones are the same way. If bone on bone rubs against each other, you know how rough the bone is. So you can imagine the kind of damage and inflammation that can be caused by bone rubbing on bone. But if it has nice, smooth, articular cartilage to slide against, then it makes a nice, smooth joint without inflammation. So in osteoarthritis, the cartilage or the lubrication breaks down between joints, and subsequently you have bone on bone, which causes pain. And when bone rubs on bone, it causes the growth of abnormal bone at the joint, which is what's called osteophytes. It's the most common joint disease. It's caused by a combination of mechanical stress, genetics, epigenetics, and biochemical factors. So either through constant mechanical stress or genetic causes, or both, you get a breakdown of the articular cartilage, and that's what causes osteoarthritis. Next, we'll talk about the clinical manifestations of osteoarthritis. So what happens here is there's certain joints that are more commonly affected than others. Most common are the hips, knees, distal interphalangeal joints, first carpal metacarpal joints, and also the first tarsometatarsal joints. So the toes, thumbs, then hips, knees. Typically presents as pain and stiffness in one or more of the weight-bearing joints, which is worse in the morning and improves within 30 minutes of continuous movement. So this is basically the opposite of rheumatoid arthritis, which we'll talk about in a little bit. So osteoarthritis is classic for morning stiffness that improves with movement. So you get pain and stiffness in the morning that improves throughout the day. You get joint swelling and effusions, which is kind of the result of bones rubbing on bones. When I said earlier that it's non-inflammatory for osteoarthritis, what I mean by that, to be more clear, is that it's not a immune response that causes inflammation. You still get inflammation within the joints because the bone's rubbing on the bone. That can cause effusions and joint swelling, but it's not the result of, we'll say, the immune system causing the inflammation. So be clear about that. With rheumatoid arthritis, it's the immune system causing the inflammation. With osteoarthritis, it's mechanical stimulation. It's the bone rubbing on the bone that causes the inflammation. So when I say non-inflammatory, you kind of have to understand what they mean by that term. And then lastly, you'll get what we call Heberden or Bouchard nodules. I think that's how that's pronounced, which are osteophytes. So osteoarthritis, treatment for that is exercise. Like we said, it improves with movement. Weight loss is key. So if you have bone rubbing on bone, a lot of times that breakdown in the articular cartilage is caused by excessive weight, putting excessive stress on joints. So if you lose weight, it helps with that. Physical therapy can help. Anti-inflammatories, glucosamine and chondroitin are sometimes shown to help. And then finally, sometimes you just have to have a joint replacement. Inflammatory joint disease, damage to the synovial membrane or articular cartilage with signs of inflammation such as fever, leukocytosis, etc. Can be infectious or non-infectious in origin. So the classic example of this is rheumatoid arthritis. It is a chronic systemic inflammatory autoimmune disease, which involves many of the organ systems, but particularly joints. So people always think about rheumatoid arthritis in relation to the joints, but it affects more than just the joints. So that's important to know. Clinical manifestations, it depends on the area affected. You can get it in the finger joints and wrist, feet, elbows, ankles, pretty much all the joints in the body. Also, you can have signs and symptoms within the lungs, the heart, kidneys, and skin. Signs include joint inflammation, fever, malaise, rash, lymph node or spleen enlargement, and Raynaud's phenomenon. So this is illustrating how with rheumatoid arthritis, it's more of an immune response. So that's the reason why you get fever, you get rashes, lymph node involvement. Whereas with osteoarthritis, you get none of these symptoms. The edema and swelling that you get is strictly limited to the joint that's affected. This is a classic picture of what someone with rheumatoid arthritis looks like. If you look really carefully at old people's hands, particularly women, people that have really bad rheumatoid arthritis, their fingers will take on this classic appearance. Sometimes I've seen people refer to this as gooseneck fingers, I think. But it's a very classic sign of rheumatoid arthritis. Rheumatoid arthritis is caused by a combination of genetic and environmental factors. With regards to genetics, most significant risks is a mutation in the human leukocyte antigen gene, or HLA gene. This gene encodes for the cell surface receptor proteins responsible for regulation of immune response. So basically, if you have a mutation in these genes, you get a heightened immune response because of the receptors that are on the cell surface of the joints or whatever tissue is being affected by the rheumatoid arthritis. There's also environmental factors such as smoking, gender. Women are 2 to 3 times greater risk for developing rheumatoid arthritis than men. Nulliparity, for whatever reason, causes rheumatoid arthritis or increases the risk. I don't know the mechanism behind that. Maybe someone can look that up for us, but I thought that was interesting. Low socioeconomic status and obesity also increase risk. This is a good kind of flow diagram that illustrates the pathophysiology behind how rheumatoid arthritis develops. Treatments for rheumatoid arthritis include NSAIDs, glucocorticoids, intra-articular injections of steroids, physical therapy, and/or surgery. Ankylosing spondylosis. So stiffening and fusion, or ankylosis, that's what that word means, a fusion of the spine and/or sacroiliac joints. It's caused by genetic factors. Again, this is another HLA gene associated disease. This disease manifests as low back pain and stiffness starting in the early 20s. You get limited range of motion of the spine, and that is all related to the inflammation. Basically causes a fusion of the bones in the spine, and because of that fusion you get a limited range of motion. It leads to a progressive loss of lordosis, which is the convex curvature of the lower spine, and an increasing kyphosis or concavity of the upper spine. So basically it causes that hunchback shape that we saw a few slides earlier, that elderly person. So they're kind of stooped over and hunched over. And then also you get a loss in that curve in the lower spine, that convex curve. So because of both of those reasons, these people have very poor posture and are kind of leaned over. That can cause pain, it can cause compression of the spinal cord. So lots of bad issues. This is a good picture of ankylosing spondylosis. You see here the lower back, they don't have that curve that people normally have, so it's straight here. And then you have an increasing kyphosis or upper curvature of the spine. Next, we'll talk about gout. Gout is an inflammatory response to excessive uric acid in the blood, otherwise known as hyperuricemia. High levels of uric acid crystallize and then are deposited in both the subcutaneous tissue and the joints. So when you have these uric acid crystals in the subcutaneous tissue, it's called tophi or tophi. And then in the joints, when the uric acid crystals deposit, it's called gouty arthritis. So you can have one or the other or both of these symptoms occurring. So uric acid is byproduct of protein metabolism, particularly purine metabolism, which is an amino acid. So when certain proteins are metabolized, you get a production of uric acid. And if you get an excessive production of uric acid because of abnormal protein metabolism, that excessive uric acid precipitates and crystallizes and then starts depositing itself throughout the body. I don't know if any of you did this experiment in chemistry class where you have a solution and you start adding solute to a solution and you get it right on the edge of where it's saturated and it starts crystallizing, and you just add one more drop of the solute and all of a sudden you just get all these crystals forming out of nowhere. That's kind of what is going on with this arthritis. You have an increased level of the substance that can crystallize, and once the concentration gets to a specific level, you get crystallization. And that crystallization, the uric acid turns from a liquid to a solid and starts depositing itself throughout the body, which causes all the issues. So, as we know from chemistry, crystallization is a function of the concentration of a solute and is also a function of the environment that solute is in. And certain things can promote or not promote the formation of crystals. Particularly pH of the body is one of the biggest things, along with the concentration that can affect whether something crystallizes or not. Some of the secondary muscular dysfunction stuff. I didn't go too crazy on the details on this. The book has a lot of stuff on that. I would read it just for the sake of completeness, so you're familiar with it. But I just kind of pared this down to the stuff that I felt was most applicable to nurse practitioners. So we'll talk about contractures. Contractures are a loss of passive range of motion of a joint due to limited muscle movement, connective tissue, or soft tissue. So basically what happens here is, for various reasons, the muscles don't move as much as they should, or the connective tissue or soft tissue. And because of that, they become very stiff and thus very limited in their motion. So the muscles and connective tissue and soft tissue prevent the joint from moving rather than, say, the bone or the joint itself. As far as muscle contractures go, there's many different causes. One of the most common is neurological injury. If anyone's ever seen someone who's had severe, say, cerebral palsy, or is sustained a severe spine or traumatic brain injury, and because of that they have had a prolonged period of limited movement because of the neurological injury. When you don't move those muscles, they become stiff and thus reduce joint mobility. In particular, with neurological injuries, there's a strong relationship between the nervous system and the muscle system. The nervous system innervates all of the muscles. That's what allows them to contract and what allows us to control their contraction. And it's critical for healthy muscles to have constant stimulation from the neurological system. If you lose that stimulation from the neurological system on the muscle, then the muscle starts becoming abnormal. It doesn't contract. It becomes very stiff, and that's how you get contractures. Tendon contractures are a result of neurological or anatomical defects. This can be from, say someone's born with cerebral palsy, can have issues. You can just be born with tight tendons. Classic example of this is someone who has tight heel cords, and you'll see these people walking on their toes. As far as people who walk on their toes, I feel like there's two different causes for that. One could be just tight heel cords themselves, but their neurological system is completely normal. And these people, they can do a tendon release and then they're back to normal. In other people, there's certain neurological disorders that are associated with toe walking. I believe people who have autism are more likely to walk on their toes. People who have sensory integration disorders, more likely to walk on their toes. I feel like people who have ADHD or ADD oftentimes tend to walk on their toes. I know this from firsthand experience because my son has this actually. He hasn't been diagnosed as autism, but he does growing up, he had issues with sensory integration. If his socks weren't on the right way, he would have huge meltdowns as a toddler. Um, Certain stimuli would, make him very agitated and uncomfortable and emotional. As he's gotten older, he's gotten better about that. He's, essentially normally functioning. He goes to regular school, doesn't have an IEP or anything like that. But to this day, he still walks on his tiptoes like a ballerina. And we've tried physical therapy. We tried reminding him to walk on his flat feet. We even got him braces to help stretch out his tendons, and none of it's worked. So I think it's just kind of one of those things. It is what it is. But long story short, if you see someone come in and they're walking on their toes, this is kind of what's going on. And that's basically all I have for you. So if you have any questions, feel free to email me or write down your questions and we can talk about them on Thursday. Thank you.